especially for kids and adolescents across this country to be receiving in terms of intervention. Before we get started, just a couple of notes here. So I'm a psychologist. Psychologists typically train to be researchers or clinicians or a combination of the two. And that was the case for the last one was the case for me in my training. They call that the Boulder model. And the idea is you're equally well-rounded as a scientist and a practitioner. In practice, people usually lean one way or the other. But that's the idea with the training. But with that training, you know, there was a real heavy emphasis on doing things that we know work through science, so evidence-based practice. And so that's the lens that would through which I tend to see the world of intervention, and definitely influences what I'm going to be talking to you about today. Now, one limitation of that is most of the research on evidence-based interventions for autistic individuals have been conducted with either children or teenagers. There isn't a whole lot out there in terms of adulthood. It's maybe been about a year since I've looked at that real carefully, but we had a graduate student do a presentation on this in our autism course we teach here about a year ago. And yeah, there's just a real lack of data. Although I will say, as we're starting to think more about adults and their needs, I think certainly a lot of those studies will follow. Okay, so just generally, when we think about interventions, we plan them and we do them with specific goals in mind. And for autistic individuals, there can be all kinds of goals that maybe someone is targeting. And it really is depending on the needs of the individual. So the treatments are individualized. Not all treatments can fit with all goals. But here's some ideas of some things people might want to work on: communication, social skills, play skills, improving kind of day-to-day routine activities, promoting academic skills, decreasing what sometimes called challenging behavior, but we'll think about like dangerous or destructive behavior. Maybe there's co-occurring medical or psychiatric conditions that are the targets for intervention. Or as we're thinking especially about transition to adulthood, promoting independence and quality of life. And regardless of what you're targeting with the intervention, it's really important that the goals are written collaboratively with the individual receiving the intervention and or their caregivers, with the progress towards those goals assessed at the beginning, or sorry, the progress assessed throughout the intervention and shared with the person in the intervention and or their family, right? So we want this to be definitely a collaborative process where everyone's having input, everyone's seeing how well it's going. And oftentimes when you're in an intervention, you may be thinking about what you can accomplish during that intervention, particularly if it's something that's a kind of intervention laid out in a manual where it says like, hey, you do this intervention for 8 weeks, or you do it for 12 weeks, that kind of thing, and see where you're at. And so you're writing some pretty short-term treatment goals when you're in a time-limited intervention like that, but always with longer-term goals and longer-term outcomes in mind. So even if, you know, we're working with a child who is not yet speaking, and the intervention is 12 weeks long, and the parents that we're working with have that long-term goal of their child being able to hold conversation with someone, we think about, okay, what are those steps that we would need to take this child from being not yet verbal to conversational. And obviously that's a that's a lot of steps developmentally in terms of language skills, but where do we start and how can we scaffold it towards the next step along the way? And there is a little bit out there in terms of the kinds of goals that adults tend to bring to therapies and interventions. So things like, again, social skills, so responding, understanding social cues, living independently, developing friendships, romantic relationships, accessing and being able to participate in daytime activities such as employment, managing day-to-day stressors, and managing psychiatric symptoms like anxiety or depression, if that's a part of the picture. You know, when I think about interventions, there is a lot out there for autism, a lot out there. And some of the things that are out there that people promote, that you might see, you know, on the internet or whatever, have very little research showing that they work. That doesn't mean that they don't work. It means that people haven't studied it, for the most part. There's a few things out there where people have studied it pretty extensively and can say, like, we don't think this works. But for the most part, just high quality research hasn't been done, right? And when I think about families and resource, right, everyone has kind of limited amount of resource, limited time, limited money that they can spend in terms of investing in intervention for their family member with autism. And so I really want people to be able to have interventions that I believe are going to be most likely to achieve the goals and outcomes that are important to that individual and or their family members. Of course, the interventions have to be available and they have to be a good fit for the patient and the family. It has to fit along with their values and how they like to do things. I'm going to skip this video for time's sake, but just kind of summarize. And then, you know, you can certainly look it up yourself. I really like this website. It's called interactingwithautism.com. And it was done by some University of California film study students. And so it's really well produced compared to a lot of autism videos out there. And this is a video of Sally Rogers, who's a kind of a very famous researcher in the field of autism. And, you know, she really talks about we're at a place now where you have options so long as you live in a place where there are options. So there's lots of rural areas where maybe we don't have every available option for a family. But in some areas we have, you know, 2 or 3 or 4 different kinds of programmings that we can choose from, even if somebody wants something fairly intensive. And that's a great situation to be in because you can really think about what's going to fit for this patient and or their family. Okay, when we think about intervention approaches, there's kind of 2 ways that people categorize. There's kind of 2 intervention approaches or 2 ways people kind of think about categorizing things. One is in terms of big intensive programs, or what they call it, a comprehensive treatment model. And these are things that are going to, you know, take a lot of time. There's going to be a lot of thought into how the pieces all fit together. And there's going to be multiple goals and outcomes you're looking at. And it's really designed to achieve a pretty broad impact on core features of autism, as well as a lot of those other kinds of goals that we talked about there at the beginning. So when we think about these big comprehensive programs, like some examples would be very early on in the research, the UCLA Young Autism Program, or what they call the LOVAS program. That's the person that was researching there. Early Start Denver model, which has been a very popular program across the country in the last 20 or so years. LEAP, which I know some school districts have adopted here in the state of Iowa. The TEACH program, which is again something that's done in classrooms, but a very comprehensive feel to it. And we'll actually see an example of that a little bit later. So these are the kinds of interventions that therapists go and get quite a lot of training in, and do quite a bit of work behind the scenes to get prepared to be able to run a big program like this. It usually involves some sort of certification or acknowledgement of being through a training for these programs. And it's not like a one-day training kind of thing. So these big programs typically have the following features. One is they tend to start pretty early with kids. We talked a little bit about early diagnosis last week, and these are the kind of programs that once a child's diagnosed, they want to put them in something that's fairly time intensive, because when we look at the research, kids who have more time intensive programming tend to have a better prognosis than those that are just having a few hours per week. There's a low student to teacher ratio or patient to therapist ratio in these programs. There's typically a family component to the programming, like maybe they're doing some parent training so they can show the parents how to use those same techniques at home. A lot of times they are integrating typically developing peers, so that individuals in these programs have some social models of typically developing social skills, and they can prompt and reinforce some new skills using those typically developing peers for support. And there's lots of measurement of how things are going, just like I talked about before, measuring the progress, adjusting what you're doing kind of based on what you're seeing with those progress. There's typically real high structure, so routines, visual schedules, those sorts of things. And hopefully, this is always the hardest part, but that you are employing some strategies that promote generalization. So it's not just that you're getting these changes in the clinic room or in the agency you're taking that's working with your child, but you're also seeing transfer those skills to the other environments that child is in throughout their days. Okay, the second way people think about interventions is to think about like what they call focused interventions. And you can think about these as kind of the building blocks. They're designed to usually address kind of a single goal or a single skill that you're working on. And so these are the things that typically make up the comprehensive treatment program, and different focused interventions make up those treatment programs based on kind of the philosophy and theory behind the programs, right? So something like TEACH has the theoretical orientation that lots of visual supports and visual structure are going to be very helpful for an autistic individual. So they're going to pick those focused interventions like picture schedules and high visual structure and those kinds of things to support the individual in the classroom. The practices are going to be defined in terms of what you're doing. Again, it's going to address a specific outcome. If you're just using this kind of on its own, not as part of a comprehensive treatment program, it's going to be shorter because you're really, using this skill or this idea until the individual goal has been achieved. A lot of these apply to difficulties that someone may have across the lifespan. And I already said this, but they can be those building blocks within a more comprehensive program. Okay, and this is going to come back here again in a couple slides, so kind of prepare you. So when we think about what's out there and what's effective as interventions, these are the 4 places that I like to steer individuals and families to. The first is the guidelines published in 2020 by the American Academy of Pediatrics. And these are guidelines actually not just about intervention, but also about diagnosis and ongoing care for the pediatrician, that sort of thing. But relatively recently revised, so just 2020, so about 3 years ago. So it's pretty up to date in terms of the research, and it's a pretty concise paper describing what works. So that's certainly something that I send families to. Another website and project that has done a very nice job over the years is called the National Standards Project. The thing about it is that the last time they updated the information was 2015. So like 8 years ago. They had hoped to have like the next update out by now, and they still do not. I'm assuming it had delays related to the pandemic, like many things, and so it's not published yet. And so the information on their website is starting to feel a little bit dated, just because they haven't put out the phase 3 results yet of what they think works well. The next website is the Association for Science and Autism Treatment. What's cool about this one is it's an organization run by parents and other caregivers, but also very still grounded in evidence-based research and looking to the science of what works when promoting different interventions. And then lastly is the National Clearinghouse on Autism Evidence and Practice. And it also published an updated summary of their research in 2020. We're going to look at this in a little bit of detail here, just as an example. The reason I oftentimes give more than one website and one project for people to look at is because they all judge things a little bit differently about like, hey, here's what we think makes the cut, but this is using these criteria to say what we think is good. And then another group might say, well, actually we think it should be this way. So if we cut things this way, these interventions do look pretty good. Whereas maybe the other organization has kind of said they don't have enough research yet, so they all do things a little bit differently. So I'm going to describe how the National Clearinghouse does things. And this is through the University of North Carolina. And basically, they've done this a few times now. But as you can see here on the graph, there's been a lot of autism intervention research done in the last 10 or so years. It's really picked up from where it was in the 90s and the early 2000s. So they have been trying to kind of keep up on this, and I do think they probably will produce revisions on a fairly regular basis. And so basically they look at the scientific journals and see what's out there, and they're really thinking about those focused interventions, so those building block pieces. And it doesn't matter if it's like more behavioral or more educational, all of that's fine. And they also look at both big studies, so things like randomized trial where they randomly assign you to get the treatment or not, all the way down to what they call single subject designs, where they're just studying changes in one person as they give the person the intervention or stop doing that intervention with the individual. And then they have this expert panel that looks at the methodology and judges whether it's good or not. I didn't put down all the criteria for that. But basically what happens then is they decide, yes, we're going to call this evidence-based if there's two well-done studies that have used group designs and experimental group designs, and those studies were completed by two different research labs. Or if there's 5 single case designs completed by at least 3 different research labs. We'll also call that evidence-based, or a combination of the two. So someone who has done a group design, and then people out there who have also done single case designs. So the reason this is important about the single case design thing is because, especially until recently, most of the research that had been done was single case design. That was a really popular way of studying the effectiveness of intervention. A lot of these interventions early on were very behavioral in nature, and there's a strong tradition in behavioral interventions to study things using single case methodology. And also, if you just think about like rates of autism, we know they've been increasing, and they were not nearly so high back in the 1990s. And so it makes sense that like it would have been pretty challenging to get a group design together, given that autism back then was considered relatively rare. So this most recent review, they had almost 1,000 studies they wanted to include. Over 80% were single case design. And I don't want you to spend too much time on these next slides, but here's some of the outcomes they were looking at. Here's some of the areas that they were saying, hey, did it work in these areas, right? So lots of social and play and communication items, but also things like challenging behavior, school things, vocational things, right? And when they pulled it all together, and they looked to say like, hey, what do we have that meets our criteria for evidence-based? They had basically 28 empirically supported focused interventions. And so this is the list of them. If you go to their website, you can easily get the summary of the things that they said are evidence-based. Now, again, the other websites may have a slightly different list, right? Because they're working off a different timeline, but they're also working off of different criteria. But for this group, this is what they put together. I'll just point out a couple things here, because I think these are always kind of fun to point out. The last time they did this list, or the last revision, there wasn't enough data to put music-mediated intervention, like music therapy, on the empirically supported intervention list. And now there are enough studies. So you can see between 2011 and then 2012 to 2017, right? There was like, in that just 5-year span, there was 4 more studies, and they must have had favorable results that suggested that yes, this is an intervention that we want to say we think is empirically supported. That same story is true for social skills. For a long time, there was lots of people doing social skills groups and other social skills interventions, but there wasn't a lot of data out there on what people were doing. And actually there was like papers and journals that said, hey, people need to be doing a better job of collecting data and publishing their results, because we all think you're doing good stuff out there, but like we don't have the science to show that. And people who were doing social skills and studying it kind of got their act together. And for a long time now, it has generally been considered evidence-based. Okay, so now I'm going to go back, and these are interventions where no matter which list you look at of the 4 that I put up there, everybody says, yes, these are supported by scientific evidence, right? These things we know work based on science. So first is applied behavior analysis, or ABA, and that includes ABA that's oftentimes aimed at treating disruptive behavior, so things that are dangerous or destructive, using specific types of ABA like functional communication training. Another type of intervention or group of interventions that are supported is called naturalistic developmental behavioral interventions, which is kind of a mouthful, but it's a pretty big group of interventions that all share a lot of commonalities, and what they tend to do is combine things from ABA with things that are more developmental in nature. So things like following the child's lead, using what the child's interested in to teach the new skill. So they kind of combine those two things together, and have gotten very favorable results, particularly with very young children. Cognitive behavioral therapy and self-management therapies that are aimed at individuals being able to better manage themselves in terms of their behavior and their cognitive thoughts about what's going on. Those are favorable as well. Social skills training, as I just mentioned, including things that use peers, social stories, scripting, and then groups. And then language training. So this is like working with a speech therapist on language skills. That has good evidence as well. A few other strategies that have evidence, visual supports and schedules. So some of those focused interventions that make up a comprehensive program like TEACH have good evidence. Naturalistic teaching strategies, so doing things, with folks kind of outside of the clinic room and where interactions and play and communication actually takes place. That makes sense to me. Modeling things either right there in the moment or through video, and really involving parents. So parent training or some sort of parent education component, so parents can be a part of the intervention with the individual receiving the intervention. Next group here are people who don't quite make, or interventions, I should say, that don't quite make the cut across all of the lists. So TEACH as a comprehensive program, even though some of the focused interventions that go into it are considered evidence-based, all together as a program, it's still considering more of like a promising practice or an emerging treatment. There just hasn't been enough research to support it as being at kind of the top of the list for evidence-based things. Tech-based treatments, music therapy, which is getting really close, or maybe actually at this point is on most people's lists, but it's creeping up there. And then developmental relational based therapies like floor time or play project also don't have enough to make it kind of to that top tier of evidence-based interventions. Now I wanted to show some videos of two different types of interventions, and for kids that I think in the videos are relatively about the same age, just to get a feel for how different interventions can be. So the first video is going to be a child in a TEACH classroom who's using a lot of those focused interventions, those strategies like visual structure and picture schedules and all those sorts of things. So let's take a little look here at what she's doing. I won't probably play the whole video because I want to keep things moving, but just to give you a feel.
My name is Alice, and I want to tell you about how I learn. I go to mainstream school. This is where I learn. It has structure with clear areas where my learning takes place. I like boundaries. There are different parts of the floor where different learning takes place. I also like to learn outdoors. I share my learning space with lots of other children. Sometimes it can get a bit much. My teachers help me when I feel like this. We worked out some ways together, which means I'm able to learn. First, they find a place for me to work, a workstation. My teachers show me my visual timetable. We work together so I can focus on what we're doing. And I can get my reward later. This helps me become independent so I can do my timetable on my own. If I get lost, my teacher uses a check your timetable card. When I know what my teachers want me to do, I go to my workstation, where I can work in my own structured way.
Okay, I'm gonna pause it there. So I get you a feel for things that use a high visual structure. And now we're gonna watch a video that is more behavioral. It's pivotal response therapy, which is kind of in between like a ABA type approach and a naturalistic behavioral intervention type approach. So some people kind of put it in one category, some people put it in the other. But she is going to be using things that the child's interested in to be teaching new skills. So in that way, it is like a naturalistic behavioral or naturalistic developmental behavioral intervention.
What page?
This.
Page?
Page 58.
If you need help, let me know.
You need help.
You do? I did.
We always knew Victoria was a special girl. She could count to 100, at age 2.
But I'm ready for vacation. We were actually completely lost when Victoria was diagnosed with autism. So we found the Yale Medicine Child Study Center online. It seemed like that would be tough on Victoria, but potentially could get some results.
Parenting is hard, but parenting a child with a disability is astronomically harder. And providing parents with strategies that they can use is what empowers me every day. I'm Pam Ventola. I'm a clinical psychologist and an assistant professor at Yale Medicine Child Study Center. In autism, the primary areas of deficit are social interaction skills, language and communication skills. That's your chair. Victoria is a patient that I've worked with for just over a year now. She's bright, capable little girl, but she wasn't motivated to engage with other people. Do you want to start with stickers or go fish? Let's play go fish. What we offer at Yale Medicine is individualized treatment. Pivotal response treatment is abbreviated PRT. It's a behavioral treatment to support language development and social interaction. You want the rod?
Yes.
Sure. For each child, we develop objectives, so very clearly defined behaviors that we want to improve. I got another green one.
I'll dump the rest.
Victoria's goals when we first started working with her included making eye contact with the person she was speaking to, and also using her language to help her begin to engage in conversations.
What did you get?
I got the bird.
Oh.
A lot of the kids that we work with, Victoria included, love bubbles. And we can use these bubbles to motivate the children to communicate with us. So the child would need to use their words. A lot of bubbles or just one bubble?
A lot.
And then I'd reinforce it by blowing the bubbles.
Okay, so hopefully gives you a sense of how that looks a little bit different than yeah. And so, right, you got to be thinking about the effectiveness of the intervention when you're choosing intervention. One thing I didn't talk about too much, but also you got to be thinking about the effectiveness of the provider you're working with. You got to have the provider that's right for you, that you feel like is collaborative and sharing your values and understanding you and your child, and that they're doing this intervention well. So those are important things. Of course, has to be available, or at least it has to be available through telehealth. That's helped out quite a lot here during the pandemic, right? And then you have to make sure that the intervention is taking a look at things over time, that you're really measuring the outcome. And if it's something that doesn't have a lot of evidence, you can still take data for your individual child, or the therapist can take data to see, like, hey, as we do this over time, is it working or not? And that's really important to be talking with the interventionist about. Just want to mention another website that is really nice because it has lots of videos of different evidence-based strategies that can be used with autistic children. It's called internetmodules.org. You do have to create a username and such, so you will provide them with your email address, but it is free. It's well done. And then here's this interactingwithautism.com website that I like. It also has nice video examples of supported interventions and also promising practices as well. There's a few things that have limited scientific evidence. One is gluten-free and casein-free diets. There has been quite a bit of research on this, and it doesn't support this being an effective intervention for autism. Facilitated communication is another one that has limited evidence, along with auditory integration training. And then there's a couple things that we do not recommend here through University of Iowa hospitals and clinics. One is chelation, which is a process to remove presumed heavy metals from the body. And then the other is very high doses of vitamins, because both of these things can be dangerous. And there's not evidence to support they're effective. Okay. So I'm not going to talk too much about medical treatment because I'm not a medical doctor, but when people are seeking psychopharmacology, some sort of medication treatment, they're typically trying to target specific symptoms. And there isn't any medication that out there that treats core symptoms of autism spectrum disorder, so like those social communication deficits. But there is some things out there, particularly to treat some of the co-occurring behaviors and psychiatric conditions. What we know is people with autism tend to be more sensitive to medications and have more side effects, unfortunately. So it's a little bit more of a process to get the right medications oftentimes. Best evidence is for risperidone for severe disruptive behavior and methylphenidate for ADHD symptoms. A few other things in terms of medical treatment is we want to make sure kids have someone who's following with them to ensure care coordination, family support, and it can make referrals to manage co-occurring problems like seizure disorders or GI problems, imbalances in dietary because of food selectivity or other food issues, disrupted sleep patterns. Okay, so now we'll talk about what people are receiving. I'm gonna go through this part pretty quickly so we have time for questions. But this is a study they did a while back ago here now, and just looked across the country. What are some things people are receiving in the community? And as you can see, the rates differ a little bit depending on whether it's an individual with autism or one with autism and intellectual disability. But behavior modification such as ABA was high. Cognitive behavioral therapy, high, right? And most people were receiving some sort of community-based service. Same study, but now looking at the schools, the kinds of things that would be at an IEP. So occupational therapy, social skills training, speech language pathologist working with a child. And again, the rates are quite high. And if you look at total across any settings, you'll see like, especially for autism and intellectual disability, almost everyone is receiving at least one kind of therapy service. And again, from that same study, this is with medications. And medication use about 50% for individuals with autism without, well, school-age children, I should say, not just individuals, but school-age children with autism. And then about 2/3 of kids with autism and intellectual disability are on psychiatric medication. It's a different study where the author really wanted to understand what therapists knew about evidence-based practice and what they were using. And it's a study where they did it in a very specific geographic regions, and it's a pretty small sample. It was done in Southern California. But what's really cool about it, because you don't see this very often, is she surveyed a wide assortment of providers. So it wasn't just social workers or psychologists or BCBAs, people who do ABA therapy, that kind of thing. It was like all these different kinds of providers that work with kids with autism to see what they knew and what they were doing. So when she did this survey, most of the providers in her sample used evidence-based focused interventions, but they also used some strategies that weren't evidence-based, or where it's not quite determined if they're evidence-based or not. When they surveyed the therapists, they said, yes, these comprehensive treatment models that we know have scientific support are a good thing, and we would choose those over something without an evidence base. And this is where it gets a little bit tricky, though. A lot of times providers were unsure what the evidence base was for certain interventions. So if they named off like a specific thing, people are like, I don't know if that has data or not. So for example, even though we definitely know cognitive behavioral therapy works well for individuals with autism spectrum disorder, to work on like anxiety or self-management in other ways. And it's very popular, as you saw in those last slides. When they surveyed these therapists, about 2 out of 5 didn't know whether or not if that would be an evidence-based intervention. So coming out of this study, she really recommended that we spend more time focusing on educating community providers about what is evidence-based. And that also, as we're doing that, we also try to teach people, what are the things that really work when we do these comprehensive treatment models, because a lot of people out in the community are going to mix and match across interventions anyway. So if we can think about like, hey, what are those essential ingredients or critical components of the intervention, that's really helpful information to share with providers. Okay. Another group of treatments is complementary and alternative medicine, and these are healthcare approaches that were developed outside of like mainstream Western medicine and are oftentimes used along with conventional medicine. And when they're used alongside conventional medicine practices, oftentimes it's called integrative medicine. These are things like naturopaths, mind and body therapies, other biomedical treatments. And they're used pretty commonly. And there's quite a range in terms of people reporting what they use. I think that depends a little bit on what the examples are that people are given, or things that they're looking at in certain studies. But basically, when there's more co-occurring diagnoses or things going on, or the autism symptoms are more severe, you see people using more of these CAM or integrative medicine approaches. And specifically to treat autism symptoms or comorbid symptoms, or to counteract negative effects of more conventional treatments. And one thing that we know is that families don't talk a whole lot with like their conventional Western medicine physician about their CAM treatments, and sometimes they don't even report usage of them. So we really encourage providers to be talking about these things with families that they're providing care for. The NIH has a great website on complementary and integrative health, and they have a section specifically on autism. Sadly, there's very little high quality research that's been done in this area, but a couple things that we do know is that there's no scientific evidence that this hormone called secretin helps. This is getting pretty old now, but about 20 years ago, they thought it might be like a miracle cure kind of thing. And NIH actually funded quickly a whole lot of studies on secretin, where they were like double-blind placebo studies kind of thing. And people were really hopeful that it might work, but when they looked at all the data, there was no effect. Hyperbaric oxygen, chelation, antifungal agents, there is no scientific evidence for those things, and they may be dangerous. There is pretty good evidence for melatonin for helping with sleep problems in people with autism. Other things they've looked at is omega-3 fatty acids, acupuncture, mindfulness, massage, oxytocin. It's not really clear at this point whether or not they improve autism symptoms, and so they say they shouldn't be used in place of conventional treatments, but it's like something where studies are still being done. Special diets may help some people with autism, but they really need to be working with a dietitian or someone who can monitor their nutritional well-being. But there's limited evidence for ketogenic diets, and that's oftentimes with individuals who have seizure disorder associated with autism. Okay, you may have noticed that in these slides, I didn't talk about therapies for dangerous or destructive behaviors, and that's because that's what we're going to spend time on next week. And now I think we have time for some questions.
Well, you did touch on this a little bit, but do you think music therapy will ever be considered traditional therapy? The question came up from the thought of seeing there's more evidence now for it.
I think it will. I do. It's kind of past that threshold now where people are like taking it seriously. And when you get there, then you start to get like a little momentum on better funding for better studies. So yeah, I think it's probably going to start to emerge on many lists as an evidence-based practice.
And with the new music therapy being recognized, have they started the movement to use art therapy?
That I'm less familiar with, and I don't think that's on most of the lists of things that are evidence-based. Yeah, so to my knowledge, I don't know of a whole lot of work in that area. That's not to say there's not some studies, but I don't think it's enough that it's like gotten into like the emerging category quite yet.
Okay, how long do you think it is necessary to give ABA training before deciding if it is the right choice for your child? I have heard a lot of mixed reviews about this strategy. Should we give it a few weeks, months, or a few months?
I would say, is it, sorry, can you repeat that? A few months, is that?
I
Or
A
a
few
month
weeks,
or
months, a month, or a few months. How long should they give it before they decide if ABA is right for the child?
a few months? Yep. I mean, unless there's some sort of like red flag where you have real concerns about a program. But just as an intervention, I think it's probably gonna take a few months, even for short-term treatment goals, to see some progress there.
Are seizures more common with autistic children?
Yes, they are. Yes, so it's a common comorbidity. But it's not like, it's not as common as something like ADHD or anxiety. But definitely if, there's concerns about seizure activity, and the person is diagnosed with autism, it's a good thing to be talking to the physician about and maybe getting checked out if the physician's in agreement, but they should, for example, see a neurologist.
Okay. Can you tell us where we can learn more about the legislative process that mandates insurance coverage for ABA for individuals with an ASD diagnosis?
Let's see where you can learn more about. So I think probably if you're looking at like kind of nationwide efforts that our organization, the Association of Scientific Evidence for Autism Treatments, I'm trying to think of the acronym. Like here. Yeah, Association for Science and Autism Treatment. They're going to have some information on that. And then I would work with some of the local organizations as well. So for example, here in Iowa, Autism Society of Iowa, I think could point you to some of those efforts, and groups that are pretty active in that area.
There's a question about if people can obtain a copy of the presentation or recording, and I will be sending that out following the session. The link to the recording does take a little bit of time to download, so give me until tomorrow to get it out, just in case. Can you talk about the effectiveness or research on CBD oil used to help regulate behavior?
I would say it depends. So there's not a lot of research that is like really well controlled yet. I think when people think about the CBD oils, that's different than some of the treatment that has been approved, like for example in Iowa, for treating dangerous and destructive behavior. Where there is maybe a little bit more research, but again, it's probably not like, it's definitely not top of the top tier, but I don't think it's necessarily in top tier yet, even for when we're thinking about medical treatments. It's still considered a little bit emerging, or maybe even like a CAM type treatment.
What kind of music are they using in therapy?
So I think oftentimes they're using music therapy to work on social and communication skills. I think those are oftentimes the outcomes that are being targeted. So working on both verbal communication as well as like nonverbal communications in terms of body movements and gestures, that sort of thing, through music. And I don't know a whole lot beyond that, but that from the things that I've read and the things I've been involved with, that's where it tends to hit.
Okay, one more question. Is there anything we can do as caregivers to help advocate that music therapy be considered a traditional service?
So I would follow the literature very closely. I mean, it's a little bit tricky when you're not on the academic side of things. But also, you know, reach out to academic people in your area. The, you know, music therapy programs, actually throughout the Midwest, you know, be talking with those people, and things do tend to kind of sometimes get approved in kind of a regional fashion. So like, oh, Minnesota's doing this thing, Illinois is doing this thing, now Iowa's going to do this thing, you know. So don't just focus necessarily on Iowa as you're looking to see what people are doing in terms of research and in terms of advocacy. And yeah, I do think so the best way to, like, I think stay up on some of the research too is to start to see who's citing the stuff that has come out on the evidence-based list. So I didn't show the big version of this. Let me just see if I can do this thing here. So I just showed like the summary version of this, but in the big document for this, it will list the names of, or the names of the 7 studies that they included to consider it empirically supported on this particular list. And then when I'm really interested in a thing, I just kind of keep track of who is citing those studies, because it's probably people who are interested in doing evidence-based work or advocacy, intervention work or advocacy. So if these are like the 7 studies that people say are really well done, if you're doing a research study in that area, you're probably citing them. And so then I find out like, hey, here's something that was just published in 2023 in this area. And then that really is what you can take to your advocacy groups and your legislatures and representatives and such, and really try to make a case for that being supported.
Okay, thank you everyone for the great questions today, and we will look forward to seeing everyone next week. Thank you, Dr. Pelzel.
Thank you.